Hi, my name's William Henderson,
And I'm B. McGraw.
and this is the Unjerked podcast. The Unjerked podcast is affiliated with B. McGraw's website.
It's the Journal of Astrological Big Data Ecology, or JABD.com.
And in this podcast, we take common discussion points on the internet and take a closer look at what the data says, what the research says. So this episode, we're going to talk about healthcare costs in the United States and why they're so high. Before we kind of get into any more detail, I want to kind of add some context. So essentially, bottom line, what is the big issue? And this is a US centric episode, but it does tangentially discuss other healthcare systems. But the big issue is Americans pay more for healthcare, both through their taxes as well as through direct out of pocket costs, premiums, deductibles, etc. They pay more for healthcare than essentially any other country. And at the same time, outcomes are worse compared to other developed countries. Obviously, we have better health outcomes than incredibly impoverished countries for the most part, but I think that's not really a fair comparison to make. I think a better comparison is other countries we're more similar to. And not only do we have worse outcomes, we also pay more for it. So there's clearly a huge issue there. And I want to preempt, we always go through a circle jerk discussion. I want to quickly touch on two of them I see a lot, and we can talk about them later. So one big issue I see sort of, I guess, more on the left side of the spectrum is essentially, there's a joke like whenever there's some military activity the U.S. partakes in, people in the comments will say like, like XYZ country is about to find out why Americans don't have healthcare. And it's like, haha, very funny. But the reality is like we pay more already. So the issue is not cost. The issue is not that we're not allocating capital, even at the governmental level. That's not the issue. We are allocating capital. It's just not being used properly. And then on the right, the big thing you hear is essentially that, any form of universal healthcare is like, a slippery slope that'll lead to like Stalinist totalitarianism. And it's just not true. That there's never been a case in human history where that was the mechanism through which, autocracy came about. So we'll talk about those things later. Anyways, so just wanted to get those out of the way. So the top level causes, and we're going to kind of decompose these, but first, the top level causes of why healthcare costs more in this country is one, waste is incentivized. Two, certain players in the system have very large profit surpluses compared to other countries, oftentimes due to skewed power dynamics. And then number three, in certain aspects, the supply of healthcare is artificially constrained in this country. Similar to how housing supply is constrained.
Is that
similar to that?
Is that from our supply of healthcare providers like doctors and nurses?
It's number of doctors, and it's also a number of hospitals. So first, if we look at the history of public healthcare, so there is this paper that it basically says the long road to universal health coverage, historical analysis of early decisions in Germany, the UK, and the US. And this is written by Jesse Bump, Department of International Health at Georgetown in 2015. So I'm not going to kind of go over everything in this, but essentially it goes over, how did universal healthcare come about? I think in a previous episode, you joked that in the old days, healthcare was like just science experiments, essentially. And there was
a lot of the case. Yeah.
Yeah. So, I mean, obviously, there were traditional healthcare, methods that I'm sure had certain levels of effectiveness, but there was a lot of healthcare, like, for example, one thing they used to do when someone was sick was they would bleed you out. They would put leeches on you. I think they did that to George Washington when he got sick. And we now know, putting leeches on someone is like, I can't think of many circumstances where that's actually effective. I would say, like, what century does like healthcare sort of become a legit thing that is scientific? Maybe like the 19th century. I'm not an expert, so I don't want to go into details, but let's say in the 1800s, you're starting to develop ways of, standardized measurement of the efficacy of different practices. You're starting to have better synthesis of drugs, etc. Okay, so before that, I think universal healthcare was kind of it was sort of not really relevant because healthcare was so poor. And I also think a lot of the structures that exist to enable, there were other things that we take for granted now that also didn't exist. I think sewage systems in the old days were a lot worse than they are now. Same with, electricity utilities used to not exist. So in the old days, it was sort of like not really a big issue. But then in the 1800s, you started to see more people implement different models. And so, one model is so Bismarck, who's the famous German statesman who helped unite the German, different German entities into one country. He was actually one person who spearheaded this German social health insurance system in 1883.
Oh, that long ago! Wow.
Yeah. Huh. So we'll talk about the Bismarck model later, but it's basically a mandatory insurance system. So it's not a government-run hospital system, but it is a universal system. And Bismarck is not a communist; he was a very conservative leader. So that's one thing to keep in mind. And then the Beveridge model. So the Beveridge report, the British National Health Service was founded in 1948, so a little bit later than the German model. But there was this guy called Beveridge who was tied to this model, and I don't know what his exact role was, but the model is basically named after him. And the national health system in the UK, it is a national hospital system owned by the government. So in that case, it is an actual nationalized health system. And then the U.S., essentially, the U.S. started tying health insurance to employment. And I think we're quite unique in the world. There might be a few other examples, but it's quite a unique system. Not many countries tie health insurance to people's employment. And so they kind of discuss that history there too. And then at the same time, I think a big thing people say is that like universal healthcare is like a communist system. It's not really, because like we said here, you saw it happen in other countries that are not communist. Granted, many communist countries did start implementing universal healthcare. But I mean, I don't know, like if the Soviet Union started like expanding, firefighters, does that mean firefighting is communist? No. So, just because certain communist countries do partake in this policy position, I don't think means that this is a communist policy. And I'll talk about that more later. So we're going to kind of go into a little more depth about the main system. So the big issue with health insurance and making it optional is something called the death spiral or adverse selection in insurance. And so there's this article from Yale Global Online. It's an old article from 2009, back when the ACA debates were happening. But it kind of talks about, what exactly this death spiral is. And so it happens when the cost of insurance goes so high that regular people stop buying insurance, and only those most likely to claim continue to pay the premiums. That worsens the underwriting experience, so the price of insurance is raised again, and then it gets worse and worse and worse. And so, insurance is essentially a form of shared risk taking where people pool money together, and most people will pay more into the system than they get out of it, or else, the insurance system
it just wouldn't really work.
Yeah, it wouldn't make money otherwise.
Yeah.
But the thing is, like, you need, at the end of the day, insurance systems always end up subsidizing the people who take out of it. It's just the nature of insurance. And so if you get in car crashes, you are subsidized in terms of car insurance. You're subsidized by the people who don't get in crashes. In health insurance, if you are less healthy or you use more services, you are subsidized by the people who are more healthy. It's just that's how all insurance works. It just is what it is. And if you make insurance optional, typically what happens is the people who don't need the insurance as much, I argue everybody needs insurance because you never know when something really bad happens to you. Even if you're young and healthy, you never know
you could suddenly get cancer for all you know.
Yeah, you might get cancer out of nowhere. You might get in a car accident. You never know. But a lot of people who think they're fine will opt out of the system, and then that leads to more and more expenses with fewer people paying in, and then it just kind of can lead to a collapse of the system. So a lot of insurance systems are basically mandatory. So if you have a driver's license and if you have a car, you're basically required to have auto insurance. It's not optional. Of course, you could argue, well, you don't have to have a car, and so therefore it's not actually mandatory. But functionally speaking, most of the country, you can't really live a life without a car, and oftentimes that's because of government laws that make it impossible to build walkable cities. And so functionally speaking, for most of the country, you are required by law to buy auto insurance. So that's just one example. And so most healthcare models are essentially in the developed world. Virtually every single other developed country has universal healthcare. So the Beveridge model, like we mentioned, is a public healthcare system. So the doctors and the hospitals work in government run, or the doctors are government employees. The hospitals are owned by the government, by the national government. And so in the UK, you have the National Health Service or National Health System. I think it's the National Health Service, the NHS.
Yeah.
This doesn't mean you're not allowed to have private health insurance and private healthcare. Private hospitals also exist. Private doctors also exist. So essentially, the NHS is a public option, essentially.
But it's so that just kind of works like how public versus private schools work in America.
Basically, yes.
That makes sense.
Yeah. And then the Bismarck model. So the Bismarck model is the one that was first started in Germany, and it's spread to many other countries as well. And so there's this article called Bismarck and the Long Road to Universal Health Coverage by Theodore Tolchinsky. And this, let's see what his affiliation is. Emeritus Braun School of Public Health at Hebrew University in Jerusalem. So he kind of talks about, the history of the Bismarck model. But essentially, the way the Bismarck model works is everybody is required to own insurance, to have health insurance. But the health insurance is not necessarily run by the government. They're basically private, nonprofit insurance companies. And there's a enrollment period, and this applies to the U.S. as well in terms of so an enrollment period is basically a period of time in the year where you're allowed to switch to different insurance or enroll in an insurance system. And so there's an enrollment period where everybody gets to compete essentially for or all the health insurance nonprofits compete to get customers. And so essentially there is a type of market, but everyone's required to participate in it. And then, the actual running of the hospitals does not necessarily happen through the government.
So how does that model work if you're not able to afford it for one reason or another?
I think in practice, I'm not sure if there's like a public option or not, but the actual prices are negotiated. The government and the insurance nonprofits actually negotiate these prices. So it's not like, so I believe in practice, the health insurance is affordable, generally speaking. I'm sure there's some sort of provision for people who have no income to have access to insurance. And then the national health insurance model. So this is essentially, this is what they do in Canada and other countries as well. But the national health insurance model, basically the government runs one giant insurance system, and everybody's required to participate. And then this single payer system directly negotiates with different, drug companies, providers, etc., for different rates, for different procedures and whatnot. So it's, similar to the Bismarck model, except it's one entity owned by the government. The actual hospitals and doctors are not necessarily working for the government, though. So those are the three big models. And then the fourth model is out of pocket, which is like most undeveloped or underdeveloped countries, you just pay for healthcare out of pocket. Um, and the US is very strange because it's essentially a mix of all these different systems. So, in terms of the Beveridge model for a government run hospitals, so that exists to a limited degree. The Defense Department has their own hospitals on bases and such. The Department of Veterans Affairs has their own hospitals. There's also, I think, some sort of bureau that provides hospitals for like Native Americans or something like that.
Oh,
so I also think that exists as well. And then the Bismarck model, a non-mandatory version of the Bismarck model exists for people who are employed. And this is most people. If somebody has a job, they usually get some sort of health insurance through that job. National health insurance, it exists for segments of the population. So Medicare is a national insurance system run by the government. It's not universal, though. It's limited to the elderly. And then Medicaid is similar, but it's limited to people who are low income. And then uninsured people, they pay for things out of pocket. Oftentimes, it ends up being emergency room visits or urgent care visits. And so it's kind of a mishmash of all the different models. And I don't like the argument that, universal healthcare is going to lead to like Stalinism, because when you look at, it's a very silly argument, but when you look at how do countries become communist, they happen because a communist vanguard party conducts armed revolution and overthrows the existing government. Like that's how it happens.
Usually look at what happens from society being really bad. I think if you have
and
better healthcare, it would be less likely to happen.
Yeah, they don't like kind of sneak in the back road through like building hospitals. I mean, it's just like, come on, that's not what happened. The Soviet, Vladimir Lenin was not like building a hospital system and then using that to like take over Tsarist Russia. That's just not what happened, and that's never how it happened. It's always been, look at what happened in the Soviet Union, look at what happened in China, look at what happened in Cuba. It's almost always an armed revolution. Perhaps there's a few examples where it was some other means, but essentially it's armed revolution by an avowedly Marxist political party. Also, communist societies, many of them do have public health care. It typically happened around the same timeline as the capitalist countries. So it's not a unique thing that happened in those systems. And also, like, oftentimes the systems in those countries are not even that good. To be frank, they're not even that extensive. So those are a few arguments. And then also countries like the UK, where they do have a government-owned health system, they still have private hospitals,
Yeah.
So like they're not preventing you from going to a private hospital. So I don't like the term socialized healthcare. I think I think you're seeing a trend in the past 20 years where people conflate public services with socialism. And I think that I don't like it when political terms are used too expansively, because it kind of waters down the definition of that term. So, if social, when people say like, oh, well, police departments and firefighters, those are also socialism. Like, no, it's not, because if that was what socialism was, like, then everybody in the world is socialist, and that's clearly not the case. What I've kind of learned through doing this podcast is like most public policy issues, they're not complicated. They're just unintuitive. So once you kind of realize like this is the reason why XYZ issue happens, it's like, oh, that kind of makes sense. But like you wouldn't think that XYZ caused the problem until you kind of learn more about it. Anyways, so GDP and government spend comparisons. So how much do we spend? So there's this health system tracker by Peterson KFF, which I think is some sort of advocacy group or think tank. And then there's also an article from the Commonwealth Fund that would be good to look over. I'm going to start with the Commonwealth Fund article. So it has a graph that looks at healthcare spending as a percentage of GDP. I think GDP is a very good metric to use because it takes into account both taxpayer funded, basically public budget activities as well as privately funded activities. So it includes both out-of-pocket premiums and deductibles as well as taxes you pay into the system. And currently, the U.S. in 2021, the U.S. Spent 17.8% of its GDP on healthcare.
That's so nuts. And it's not even a spike or anything. That is a straight trend.
Yeah, in Germany, and then a lot of the European countries cluster from 10.1 to 12.8. So Germany's at 12.8, Norway's down at 10.1. Korea, I believe, is at 8.8%. And so other countries spend much, much less on healthcare than we do. Another sort of unrelated trend that I want to mention just for the sake of mentioning it is the actual percent spend was much lower in the past. So in 1980, the U.S. spent 8.2% of its GDP on healthcare. There's a very simple explanation.
Go before 1980, like were we basically in the back before that? Well, it decade?
Doesn't. I couldn't find a graph that goes before for this specific set of data. But there's an easy explanation as to why we're paying more for healthcare. All countries are paying more for healthcare now than in the past.
Yeah, it looks like everyone ticked up.
Yeah, so why do you think that is? It's a very simple explanation.
I don't know.
We're just an older population.
Oh my goodness, that's right. Everyone aged.
Yeah. So this is what happens when, and this is why the sort of demographic pyramid turning upside down is a very dangerous thing, because it just, the amount of money you have to spend to support things like healthcare get higher and higher while the tax base gets smaller and smaller.
Yeah.
So the U.S. spends 3 to 4 times more on healthcare costs than South Korea, New Zealand, and Japan. And, that's a very high amount.
What is that reverse pyramid effect like across country? Like, do we have more boomers than other countries, or is it about the same?
Other countries, places, we're actually not nearly as bad because we have a lot of
immigration. I heard Asia's really bad.
Japan is really bad. China is going to get pretty bad. South Korea is pretty bad. Germany and Italy are really bad. The US and Canada, incidentally, are not doing as poorly just because of the amount of immigration we have. So, although immigration there are other problems associated with it per our episode we discussed before.
Yeah.
We're the only high income country that does not guarantee health coverage. And our outcomes are poor. U.S. life expectancy at birth is 3 years lower than the OECD average. So we're not, it doesn't look like we're the worst, actually. Or actually, no, we are the worst.
Well, I thought that was
not the worst out of all countries, but the worst out of, they look at 2, 4, 6, 8, 10. There's 12 countries they're looking at here. In Europe, Australia, New Zealand, the UK, Japan, Korea, etc. And then avoidable deaths per 100,000 is higher than the OECD average. Huge spike in 2020 that has to be COVID.
What is an avoidable death?
I don't know the exact definition. Avoidable mortality includes deaths which are preventable and treatable. So I suppose a death where if they were provided, the standard of care for that disease, they would not have died within a certain period of time. Obviously, everyone eventually dies. But we have much higher infant mortality and maternal mortality compared to peer nations. I think we can skip this one. Deaths from assault, that's a different issue. Obesity rate, I also think that there's other reasons for that. We're more likely to have multiple chronic conditions than peer nations. Highest death rate from COVID compared to peer nations. Among the lowest rates of physician visits and practicing physicians. So on average, people go to doctors less than peer nations, and there are fewer doctors compared to peer nations. We also tend to have a very low number of hospitals, very low number of days. When you go to the hospital, you're in for a much fewer number of days, and the number of hospital beds per capita is much lower. And there's more and more data. We don't have to go through all of it. And then the health system tracker from Peterson KFF, they basically do this simple regression that looks at the GDP per capita versus healthcare consumption per capita, or healthcare spending per capita. And the US is clearly an outlier. It's far above the regression line. In other countries, there are countries below the line that spend less than you would expect. A lot of them, like Ireland, is a tax haven, so that probably explains it. Luxembourg is a microstate. Norway's kind of on trend. But generally speaking, the wealthier a country is, the more they will spend, just because that's kind of how purchasing power works. But the US, even then, spends much more on healthcare. It's just off trend. Health spend per capita per year is $12,555 in the US. And for comparison, Switzerland's about 8,000. Japan is as low as 5,200. So I don't need to kind of continue to go through these stats. The point is, there's a pretty clear gap, and it seems to not make sense.
No, it doesn't.
Yeah. So where does your healthcare dollar go in terms of what your insurance company spends money on?
That's a lot of the conversation in the Reddit comment sections. Is it more the doctors? Is it more the drugs? Is it more the admin? And everyone's blaming everybody.
So there's this group called the AHIP, which is an advocacy group, and they say, where does your healthcare dollar go? And I believe this is specific to like the insurance. So when you pay insurance premiums, where does that money go? What does the insurance company spend money on? So for every dollar, 2.4 cents is profit. So health insurance companies actually don't have a super high profit margin. It's 2.4%, which for comparison, tech companies can have up to 20-30% margins if they're really strong companies. Companies like airlines usually have like a near zero profit margin. So that's kind of the range you see. So 2.4% is on the low end. But 24.2% goes to prescription drug costs. So a quarter of all
a lot. Yeah.
goes to prescription drugs. 17.6% goes to inpatient hospital costs. So when you go to the hospital, that money is used to pay the salaries of the doctors and the nurses, the admin, depreciation of the equipment, etc. All sorts of costs tied to that. 19.9% on outpatient hospital costs, 3.2% on emergency room costs, which I suppose is lower than I thought.
Outpatient versus inpatient cost-wise?
Inpatient is when you have to stay in the hospital for a couple days. Outpatient is when you just kind of visit the doctor and they're like, hey, take this or whatever. And then you kind of leave.
Oh, okay. Yeah.
Huh. And then 11.6% are doctor visits. I guess so doctor visits are more those really quick in and out thing. The difference is, so inpatient is when you have to sleep overnight at the hospital. You're hospitalized. Outpatient is when you go in, you get treatment, you get scans, you get surgery, and then you leave at the end of the day. Doctor visits are the more simple, just kind of go in, consultation. 7.1% on other outpatient care, ambulatory surgery and labs. 3.4% on taxes and fees, 3.3% other fees and business expenses. And then, the rest is just tiny. Cost containment, quality improvement, other admin. They're all small.
Yeah, it looks like most of this is like the actual like healthcare, being in the hospital and doing things.
So the drugs are also, the
drugs
doctor
are pretty
prescribes
high.
the drugs to you.
For some reason, I thought the drugs were going to be higher.
Yeah. So we'll talk a bit more about that. So the Commonwealth Fund actually goes into detail. So it says high U.S. healthcare spending. Where is it all going? And they actually do an analysis and they say like what percent of the let's say they're benchmarking against other countries that have lower expenses for healthcare, and what percent of the extra cost can you explain in relation to specific causes? And so 15%, 15% of the extra cost is because we pay more administrative costs for insurance. So that's, administrative bloat related to insurance processing. Another 15%, 1.5, is US providers spending more on administrative activities. So that's hospital administration. 10% is we pay more for prescription drugs in the US. 10% is physicians earn more in the US. So they bring in more salary, and that's obviously a payroll expense. 5% is that registered nurses earn more. And then sub 5% is US invests more in medical machinery and equipment. So that explains about 60% of the difference. I'm assuming the other 40%, they either couldn't find a variable or it was too small to count or something to that effect.
Yeah.
But it's kind of peanut butter spread across the board in terms of like what causes higher expenses. The medical equipment is lower than I expected.
You thought medical equipment was going to be higher?
Well, I know it's expensive, but I suppose not. It's not expensive in relation to other countries. It seems like people pay, but essentially a lot of it is admin. A lot of it is prescription drugs. Doctors get paid more, etc. So, I mean, is that kind of more or less what you were expecting?
I don't know what I would have expected, to be honest.
Yeah,
because most of the discussion just always felt like noise to me.
And then, so we're going to add I'm not going to mention every source for this next section, but we'll add it in the notes. But essentially, to compare profit margins. I don't think this is, so there's some nuance here. So I think the profit motive, so some people say healthcare should have no profit attached to it, because when you have a profit, that's essentially money that's taken out of out of an organization to pay shareholders, and hence, it has to increase costs to patients. But the flip side is, I think, when an organization is for profit, assuming it's a well-designed market, that usually incentivizes less waste. So there's two kind of competing. On the one hand, yes, profit does mean money coming out of your pocket to help pay for shareholders. But the flip side is it does probably it's incentivized less administrative waste. So this is not the perfect comparison, but I thought it was useful nonetheless. So medical devices, according to this report I found, medical device companies have up to 20-30% profit margin, so they make a decent amount of money. Pharmaceutical companies have about a 13.8% profit margin. So again, they make a lot. Pharmacy benefit managers, which we'll talk about later. So pre-tax, they make about 4%, which is not super high. Hospitals, their profit margin is about 3.8%, which is also not too high. And then health insurance, 3.3%, also not too high. So in pure profit,
a lot of it's, it looks like the medical devices and big pharma have the large profit margins.
I think the flip side is a lot of the admin waste. In the previous article, they mentioned there's insurance-related administrative bloat and hospital-related administrative bloat. So even though hospitals and health insurance have lower profit margins for shareholders, they actually have a lot of administrative staff that perhaps in a more lean system wouldn't need to exist to the same degree. So it's a little nuanced, but that's something else.
That makes some more sense. That's I definitely would buy that because all the hospitals and health insurance is kind of general use, while like most medical devices, I imagine, could be high profit margins, because I don't think a lot of it would like ever have competitors, or at least not. I don't think there'd be a lot of market competition.
Yeah. Also, this is unrelated, but in terms of so hospitals in the U.S., who owns them? who runs them. It's actually a patchwork. This is sort of an aside, but it's actually a mix. So there, like we mentioned, there's some federally owned hospitals in the Defense Department and the Department of Veterans Affairs. There's also a lot of municipally owned hospitals. I don't know if there's a lot of. So I suppose university hospital systems are state owned, probably. And then there's municipal hospitals. Yeah, and then there's municipal hospitals where local governments will have hospitals sometimes. There's also privately run hospitals. So there's health systems that are for profit that run hospitals. There's also nonprofit hospitals. Many of them are religiously affiliated. So you'll have like a Presbyterian whatever hospital or a Catholic whatever hospital. So those are quite common as well. So it's kind of a mix. There's no model that really predominates. All right, so that was episode 1 of our episode on healthcare costs. We'll go with episode 2 next.